There has been a lot going on over the last really 3 to 5 years, and what's actually quite heartening is the fact that we are viewing children and adolescents as different than the NFL player, which is a good thing. Just so you know, I'm disclose that I'm a test author. One of my professional areas is actually to try to fill the gap in the kinds of tools that we have to assess many of the problems that we see with kids. And a number of these things have been CDC funded. So today's objective is to really give you a good working understanding of this issue of concussion, to develop knowledge of some evaluation and management tools and strategies to deal with this rather common issue, and then to know the available resources. We'll talk a little bit about the clinic that we run and some of you may be familiar with. So we'll go through some basics of what this injury is, the evaluation, the treatment management process, and then probably most importantly, the question of when can I go back to play, Doc? Because you are asked that question, and you may really wonder what is the current information out there. Let me start out with a plea. Okay, this is based on just lots and lots of experience in working with kids and families. First of all, there is a certain segment of us that thinks that, concussions, they're not a big deal. Kids get over them. Hopefully you appreciate that this is a brain injury and that this is not to be dismissed. Secondly, up until just a few years ago, we basically relied on the patient report of their symptoms. And I hope that by the end of my talk today you will understand that that is not where you want to end your evaluation and management, particularly of an athlete going back to play a collision sport. Also, I'm going to talk about a standardized protocol, the acute concussion evaluation, that gives you, I think, a set of structured questions to really ask about this injury. And to manage that student athlete actively and fully, never, ever, ever arbitrarily assign a set of days that individual should sit out. There is no magic to 7 days, to 10 days. We don't know, and you'll see some data that the length of time to recovery varies widely. And if you choose 7 days, typically in the adolescent, you probably sent 60% of our athletes back too soon. Never allow return until complete recovery, and we'll talk about what that means, and follow the kids to that recovery. And you may be saying, how am I going to do all that? Well, you've got some resources in the area. Certainly our SCORE clinic is one of them that can really work with you to manage these kids. And you're going to hear me also, I refer commonly to the kids that they are student athletes. When I was in high school, when I was in college, it was a great time to play sports. I played football, I played rugby, all those crazy sports, and that was definitely, the highlight of my day. But that's not what I do today, obviously. If I wasn't the student part, I'd be doing many other things. So the question is, when this injury occurs to the head, when you get that phone call, when that patient comes into your office, what are you going to do about it? What's your clinical protocol to diagnose and to treat? And also, what sort of guidelines might you use when you're trying to return that student athlete back onto the field? What tools can help? And I want to strongly, strongly encourage you, and also you have a part of that in your packet, to reference the physician's toolkit. I was one of the primary authors of this with the CDC. It was introduced 3 years ago, and it's had, I think, pretty incomplete penetration into the professional world. And also to be aware that we have held 3 consensus conferences over the last decade, the last one being in Zurich, that looks at the body of evidence that we currently have and what are our best guidelines for managing and returning an athlete. In your handout, you actually have this paper. This is the consensus guidelines from the Zurich conference that talks about, first of all, what the injury is, Actually, uniquely in the Zurich conference, we had a specific section that looked at the youth athlete. And I was very pleased because in the prior conference in Prague, there was a lot of talk about it, but less of a focus on that. And we began to look at the literature. Let me also tell you that coming soon, and you may know this, you may not know this, this summer, the American Academy of Pediatrics will be publishing their revised guidelines. And those guidelines actually will largely reflect what we've done with the Zurich consensus statement. The American Academy of Neurology is also revising their practice parameter. I'm on that committee, and that should be out in spring of 2011. So there's a lot of updating because there's been a lot of new information to help guide us. As you may know, and as Mark mentioned, there's been lots and lots of attention in the media over the last number of years. New York Times has published many, many different articles. When I saw this come out, I was on the one hand happy to know that we were making some mention of this injury, but part of my concern was that people would think of this as a football injury, and this is not a football injury. The good news is about a week later, Alan Schwartz wrote this about girls, and I will tell you that we must pay attention to girls' sports as much as boys' sports, and that includes cheerleading. In order to build a better mousetrap here and to really safeguard kids, we've got to think about how we can manage this. And so in doing so, one of the things that we're doing now is really trying to help with early identification and recognition, actually even before they get to your office or to the emergency department. And that's training coaches, training parents, informing kids about this injury and its risks. Also, we're doing a study, I'll tell you a little bit about at the end, where we're looking at the care pathways when kids go through the emergency department. What is the best guidance that we can give families as they leave the emergency department and really return to the primary care world in taking those first steps? We've done the study of the Acute Concussion Evaluation Emergency Department. But also, as I mentioned, when the call comes to the primary care physician, what are you going to do? And we'll talk about the ACE. And then, of course, when to send that child to specialty care, where you have questions either about the nature or the complexity of that injury and its recovery, or some specific kinds of treatments that we want to think about. Education is obviously critically important. We have multiple toolkits now that the CDC has put out. The problem right now is that they are somewhat passive in their orientation. Some of you may be aware that we put into the Maryland legislature this year a bill, which did not pass this year, hopefully will next year, that will mandate education of coaches, parents, student athletes, as well as the return to play guidelines that have been medically established. So let's talk about the injury. We know that millions of kids actually have these injuries a year. We know that the vast majority of brain injuries are in the mild mild category that would be classified as concussion. Over the last number of years, and when we were doing our work with the Physician's Toolkit in 2007, we modified the previous estimates of 300,000 concussions to instead 1.6 to 3.8 million with new epidemiologic information. Part of the problem that we have with this injury is that it's called many, many different things. And that can be confusing, mostly to the parents or to the coaches. Is a minor head injury the same as a mild traumatic brain injury is the same as a concussion? But of course, the kids think of it otherwise. They think of a bell ringer, they think of a ding, they think of a head bonk. They have all different kinds of terms. And the bottom line is, on the one hand, we get concerned about the minimizing of the problem by the terms on the right-hand side. But if that's out there in the community and what's being said, then we need to draw the linkages here between them. From my perspective, and from the perspective of most, a concussion is a traumatic brain injury. It falls in the quote-unquote milder category. But I will tell you, many of the patients that we see in clinic don't feel that it's a mild effect on their life. To define this, we can look at the physician's toolkit, and we define it as a complex pathophysiologic process affecting the brain that's induced by traumatic biomechanical forces that are secondary to a blow to the head. And that blow can, well, actually, the blow can be to the head or it can be indirectly to the body that then lurches the head forward in a acceleration-deceleration manner. That then results in a disturbance in the function of the brain that we actually think is more of a neurometabolic disturbance rather than a structural or anatomic injury. Because of that, then, our methods that look at brain structure, CT and standard MRI, are typically normal. And of course, we do, and you'll hear Dr. Adabaki talk about the decision rule, but we do at times scan kids because of concerns for bleeds or significant edema. What we also know is that these injuries infrequently result in a loss of consciousness. Only 10 to 20% of the cases actually lose consciousness. So that's not your first indicator. And in fact, our data at this point tells us that the typical momentary, and by momentary, usually 30 seconds or less loss of consciousness, is not a predictor of severity of the injury. Now, when you have longer periods of loss of consciousness, that can be more predictive, but in the typical situation, it's not. This concussion then results in a whole constellation of symptoms, and this is why we have to do a full assessment of symptoms that involve physical, cognitive, emotional, and sleep-related symptoms that I'll go into in a minute. What's interesting and at times challenging about this injury is that that constellation of symptoms can be quite variable, with kids that have more of a physical or somatic presentation, some more of a cognitive presentation, some with or without sleep-related problems. So it's important that we look across all of those symptom types and track them carefully. Also, when we look at our standard brain injury criteria, the Glasgow Coma Scale, these kids are all at the upper end. In fact, many of them are a Glasgow Coma Scale of 15. And as I mentioned, it's rare. Well, in the ICD, they talk about concussion and 1 hour or less of loss of consciousness. But quite honestly, it's a rare event that we see somebody with a concussion with anything even resembling that. And then again, that there's no structural abnormalities, no skull fractures, bleeds, known lesions. So let's just kind of review real quickly what actually happens in this timeline of a concussion, because I think that's an important component here then for your evaluation, your assessment. Here you have two girls playing lacrosse, and one takes a stick to the head, which is actually the most common mechanism. Again, loss of consciousness typically happens less than 1 out of 10 times. If it does, again, typically for seconds. What we see is relatively more common, but again, less than 50% of the cases, is some disruption of memory formation, either for information right before the injury occurred, that is retrograde amnesia, or for information right after the blow, that is anterograde or what we call post-traumatic amnesia. You want to assess both those things, and again, we'll show you where you do that. And then looking at the effects on neurocognitive functioning and on that array of symptoms that we've mentioned, all very important to look at. And these, again, can occur for hours in some cases, days, weeks, and we have kids where it's months and sometimes beyond that. The other thing that's important to recognize is that the child that comes into you may be very different than the next child that comes into you. And we have some initial information that tells us that pre-injury risk factors may modify that outcome. That is, kids with attention deficit hyperactivity disorder, learning disabilities, their own history of chronic headaches or family history of that, a history of recent concussion can all prolong the recovery period. And it's very important to know that, because if you are thinking about managing that youngster, you need to think about all the factors that may guide you in terms of your length of management. So here we look at defining the injury characteristics, we look at doing a full symptom assessment, and we look at assessing what those risk factors are. Now, what we've learned over the last 10 years or so, again, is that this is more of a neurometabolic disorder. We talk about it as being a software problem. It's an abnormal release neurochemically that then impairs the brain for whatever period of time. And some of the work out of UCLA has defined this in animal models. And actually, we think that this is paralleling pretty closely what may be happening in the human brain. And there have been a number of studies with young adults and with animals looking using more advanced imaging methods, MR spectroscopy, diffusion tensor imaging, functional magnetic resonance imaging to basically examine that software problem. We actually have a study that we're starting right now looking at that in children. It's the first study looking at MR spectroscopy and tracking these kids over time. Actually, you have on the back of your first page, you have some information about that if you have kids that you'd like to refer into that study. Here, I think, is a very, very important slide to recognize. This is a study that was done in Pittsburgh where they tracked high school athletes, and this is actually a community study. So they had the total group of kids, and these were the injured kids that came in, 134 high school athletes. And this is the variability in recovery time. And what you can see here is that, again, at week 1, which is 7 days, only 40% of the kids had recovered. Week 2, at the end of 2 weeks, almost 70%, but not quite. After 3 weeks, 80%, and so forth, moving on. When you get out to 4 weeks and beyond, there's still roughly about 5% of the kids that had not recovered. The question or the issue right now is we don't know how to predict whether you are that faster, quicker recovery person or that slower recovery person. So every kid has to be tracked carefully. And again, it's also why there is no prescriptive number of days after the injury to return a player. It's a very individualized process. And again, you'll read that in the Zurich statement. The issue, of course, here is that if we don't identify and manage these kids, they are at significant risk. They'll take longer to recover. They are more likely to be re-injured because that brain is much more vulnerable to re-injury. And those second and third injuries that we oftentimes see in our clinic result in a much more significant set of problems. And one of the big issues that we are managing regularly are the academic or school-based problems. This time of the year, I can't tell you how many kids we're managing where final exams are their biggest challenge and, frankly, their biggest horror because they cannot focus and concentrate. They can't think as quickly. Their headaches worsen. Their fatigue kicks in, and their capacity to perform is significantly impaired. So all of these kinds of things are really critical as we think about managing these kids carefully. And we may not be able to prevent that first injury, but we certainly can prevent that second injury from happening during recovery. So the question then is, what's my clinical protocol? What do I use? And this is where the acute concussion evaluation comes in. And again, you have as that second page, or that in your packet, the evaluation right there. And I'm going to review that with you. This is out of, again, the Heads Up Brain Injury in Your Practice that I'll share the website with you in a minute, where you can pull all these things down, or you can go ahead and order them from the CDC, either by phone or by website. This is a paper that you also have in your handout that we wrote that looked at basically the reliability and the validity of using the acute concussion evaluation. And it is reasonably predictive of later symptom presentation. And I won't go into a lot of detail right now, but I encourage you to take a look at that. The bottom line to this injury is that we want to identify as best we can the fact that a blow has been taken to the head or to the body, and that there is some change in function, that is, some signs or symptoms that present. The ACE then is basically set up as a clinical protocol for you, a set of questions that you can ask that help you to guide your diagnostic process and your management. In our work in that paper, we looked at kids from age 4 through young adult years. And the symptoms really do not change. The same array of symptoms are relevant throughout that age span. The challenge that you will have is the reporting of them. Certainly with young kids, they are not necessarily good reporters of this, and our own research has shown that. But you can use the ACE actually with a parent, and you can ask, what have you observed? What are you hearing your child complain of? In fact, most of our respondents in the study were parent reporters of their kids' symptoms. We also use this to link, to give you a good profile of what are the symptoms and how do I then go ahead and manage those problems along the way. So, as I said, patient or parent, or somebody who knows the youngster, another can be the reporter of those. And you're assessing now for the presence or absence of a set of 22 symptoms that fall into the 4 categories. It takes about 5 minutes to conduct. We studied in our sample from start to finish how long it took to do this. The key elements, again, as you saw that timeline of the injury, defining the injury characteristics, assessing for those symptoms, identifying the risk factors that may modify recovery time. And then also on the form are the red flags for neurological deterioration, the things that you want to guide your patients as they leave the office to observe carefully, and should they occur, to seek emergency medical attention, establishing the diagnosis and then a follow-up plan. All that's on that form. So if we look at it here, the top of the form is the injury characteristics that looks at what actually happened. Do you have some reasonable evidence that there was a blow to the head? And then the amnesia questions. Are there any events just before the injury that you or the person does not remember for after the injury? And it's a simple yes or no in that case. If you can understand the duration of that, that's great, but we often find that that's pretty unreliable. Kids just don't know how long they didn't remember. And unless you have an observer right there, it's a challenge. We also ask questions about loss of consciousness, and again, typically that's from an observer or a reporter, and then any of the early signs that people observed. Seizures are pretty rare after this injury, but certainly we want to know if that's the case. In our sample, it's less than 1% of the kids that report seizures. Here's the symptom checklist. So this is really, the main body of what you're looking for. And you're looking for those physical symptoms of headache, nausea, vomiting, balance problems, going all the way through the sensitivities to light and noise, the cognitive problems. We talk about kids, feeling foggy, just not feeling themselves, kind of feeling fuzzy in the head, like they can't quite focus. I often say it's like that you just woke up feeling, you're not quite fully there. Difficulties with concentration or memory, or sort of feeling slowed down. The emotional symptoms are important as well. Kids oftentimes are much more irritable. They can't tolerate stress or stimulation very well. And then the sleep problems. And obviously you have to have had a night of sleep in order to assess this. But is the youngster having difficulty falling asleep, maintaining their sleep? The other question you'll see with exertion is, do these symptoms worsen when the youngster is doing physical activity or cognitive activity? Very important for your management. And then we often ask an overall rating. How different do you feel from your everyday functioning, and a rating there from 1 to 6. Again, the risk factors, what are we looking for? Is there a history of concussion prior to this? And again, we get most concerned with concussions that have happened within the recent past, within the last 6 to 12 months, but certainly we want to know a full history there as well. Headache history of either of the individual or of their family. Migraine in particular is a challenge here, and we see that kids can have a longer period of recovery when there is that history there. A developmental history, as I mentioned, learning disabilities, ADHD, other developmental disabilities. These are all issues with different brain development, and we think that with that neurological difference that then has imposed on top of it an injury, the recovery process is longer. And then a psychiatric history of anxiety, depression, and again, prior sleep problems can really exacerbate this recovery. The red flags here for neurological deterioration, we think about headaches that worsen substantially, seizures, obviously any focal neurologic sign, when there's repeated vomiting, slurred speech, Kids are no longer recognizing familiar people, and so forth as you move along. These are all unusual changes in the behavior that would suggest the need for urgent or emergent care. And then the CDC, of course, when we work with them, they're good bean counters. They want to make sure we're using the proper codes and to consider using the concussion codes here. There's a variety of codes that are out there that can be used. We'll have a much better chance at epidemiologically understanding this injury if we can be a little bit more specific. For kids that fall outside of the concussion or mild TBI and are in now more the moderate, we then think about other codes such as the 854 codes, intracranial injuries, and I won't go into that in detail now, but the point is trying to kind of begin to specify those codes. And then what's the follow-up care here? Are you going to monitor that youngster over time? Are you concerned that you want to refer that youngster either to the emergency department or to a specialist? And then that again, the end of the form gives you that sort of cue to do that. What are the indications actually then for specialty evaluation? Certainly any kids that have a history of multiple concussions, multiple mild traumatic brain injuries, we want to have those kids looked at, both because we are concerned about the potential of cumulative effects, but also there may be some behaviors that need to be looked at here and modified to reduce that risk. Anytime we see persistence of these symptoms, and persistence meaning they are not changing and it's starting to approach a week or beyond, now you're affecting kids' school, now you're affecting their everyday lives. And also if you're concerned that programming at the school is necessary, and it many times is, in fact I would argue it always is, but beyond the level that you're comfortable with, certainly that's a big thing that we do in our clinic. And the return to sports competition, again, you will see in the Zurich statement here that the clearance of kids really is much more complex than whether they report the end of a headache or not. It's a full set of questions that we ask about the full set of symptoms, about whether physical or cognitive exertion is bringing those symptoms back, whether their cognitive functioning has returned to normal. These are all sensitive indicators that have had a reasonable amount of research done. When we look at what happens neuropsychologically, we know the concentration, the ability to hold information actively in your working memory, the ability to learn new information and to commit that to long-term memory, and then to pull it back easily, the speed of processing of information and your basic reaction time all can be impaired. And that's actually what our tests are looking at. Some of you may have heard about places where we do baseline testing of athletes. We take care of the Washington Capitals and we consult with the Ravens at the professional level, and they all baseline test their kids. Most Division I, Division II, Division III sports are doing this now as well. The idea of what is your base level of these functions, and then after the injury, let's evaluate that and manage that return to that normal level. Something we actually have actively happening in Howard County, and we're doing it in some other counties. In Montgomery County, we don't have athletic trainers in our high schools, so we are more than behind the 8 ball there. So the baseline testing is not a simple process. You need to have the right people in place to do that. In the Zurich paper, there's a whole discussion about the neuropsychological assessment process, and again, the idea that it's very, very useful as a component of the management here. And that, again, this is not a simple doc-in-the-box tool. This is something where you really need people who are trained to interpret these tests and that certainly understand them within the sports context as well. And again, there's articles in the British Journal that talk about that. And the bottom line is, ideally you'd have that pre-concussion baseline testing of cognitive functioning, but also their symptoms. And then after the injury, we can evaluate both cognitive functioning and symptoms to see where they are and track this over time until the youngster is ultimately returned both at a cognitive level, as this particular example shows, between days 12 to 16, although symptoms are not back to normal until after that. And the cognitive functioning and the symptoms don't always track together, and they both have to be followed carefully. What's also important is to recognize that these exams, as we all know, fall in the context of the clinical history of that youngster. Again, is there a developmental, is there a medical reason, is there a recent history of injury? Also, we need to understand, particularly when it involves the neurocognitive testing, do these kids understand the testing? Is that valid testing? What's their clinical presentation? Is this a kid that is just extremely fatigued? Is this a kid that's very anxious? Is this a kid that's got headaches that are impairing their performance? And again, when we rev up that brain with cognitive activity, do we see that they become symptomatic? For some kids, their testing can be absolutely normal, but the problem is their effort to make that testing normal has worsened their symptoms. That's still a sign that neurometabolically they have not returned to where they need to be. When we think about managing this, we talk about the rest of the brain. Now, historically we think, okay, so we don't let that kid go back out on the playground, we don't let him go back out on the field or the court or the ice, all right, physical rest. But what we also know is that the neurometabolic system is particularly challenged by cognitive activity, and so we talk about cognitive rest. And that is a challenge because all kids, with the exception of these next 2 months, are in school. And the ability to manage those school demands can be a substantial challenge to them and really requires us to help. So the keys here in helping and managing recovery is resting the brain, and I highlight the need for good sleep. Now, many of us know that our adolescents normally have pretty lousy sleep patterns, many times because of the academic demands they have, but other times because of other poor habits they've established. So sleep is critical, though, and a critical time when that brain can begin the recovery process. Obviously, we want to make sure that they are kept out of harm's way and there are no additional forces applied to the head. So it's important to recognize that although that lacrosse player is no longer allowed to play lacrosse, that doesn't mean they go back on their skateboard. That doesn't mean they go back out and are running around and playing touch football or basketball. They are kept out of all activities where there's any risk of re-injury. And then again, managing the exertional activity, avoiding activities that produce symptoms. I tell kids and families, I don't want to totally isolate you, but I want you to pay attention to your symptoms, and anything that increases those symptoms, you need to back off of and do less of until there are no symptoms. So overexerting the body and brain is important here. When we think about, again, the mental or cognitive rest idea, again, any activity that involves prolonged concentration, prolonged homework, with kids that have 3-4 hours of homework a night after a long day, that's a real challenge. And we're regularly making recommendations that we cut that back. Kids that have the block scheduling, hour-and-a-half classes, is a real challenge for them to hang in there. And again, modifying that schedule. Prolonged days, we often start kids out on partial days and see how they do and just build them up as far as they can tolerate. So when we think about that, what do we instruct parents and athletes to do immediately post-injury? And another handout that you've got is something called the ACE post-concussion homeschool instructions. This is actually an adaptation of what we're doing in our emergency department study. And this gives you some primary guidance. First of all, it talks about what are the things where you want to seek care emergently. And this is literally something you hand out to your families. So these are the red flags for neurologic deterioration that they would contact you or the emergency department right away. And then the common signs and symptoms that they need to be paying attention to. Ultimately, what should they be doing in returning to their daily activities? And again, we give guidance in terms of lowering the amount of activity, being careful with both physical and cognitive activity that worsens symptoms. And then various do's and don'ts that we want to encourage them to do or not to do. And then what do we talk in terms of school return? And the back half of the second page of that handout is the returning to school guidelines. Many times after these injuries, I would recommend at least a day or two out of school. In the acute aspect of this injury, we don't know whether those symptoms are going to worsen or whether they're going to improve right away. And I'd rather we use the home as the laboratory to find that out rather than the school. Now, I know sometimes our families are not able to have our kids at home. And if that's the case, we really want to employ the school nurse to monitor the kids real carefully. And then there's some guidance on this form for what the teachers can do, how they can help kids. And then finally, the return to athletics, just some basic guidance there. So the idea here is to give you some information that you can review with your patients around this injury. There's an article, a short little article that we wrote on cognitive rest that we oftentimes offer to the families just to give them an idea and to take into their school. I know that some of these materials may be posted on the website, and I'll see if we can post this article and actually the whole handout so that we can have it available to you. So the whole idea of cognitive rest is just making sure that we are managing the amount of mental activity. And the bottom line is, this really is a continuum of activity. The only time that you would truly have no cognitive activity is if you're asleep or comatose, right? And so it's not a matter of simply saying you do nothing mentally. It's all about managing the amount of activity that does not worsen or exacerbate symptoms. And so we talk about therapeutically limiting the amount of activity that we think is going to interfere with that neurometabolic recovery. So I like to refer to it as cognitive management more than just simply rest alone. One of the things that we do in our clinic is that when we're evaluating kids, we use something we call the ACE care plan, which is a form of those home and school instructions, but that's tailored very specific to where that youngster is. And we give multiple copies of this to the family to give them to the school, to the coach, to the school nurse, to the teachers, so that we can really guide. All right, so finally we're going to talk about returning a kid to play. When do we do that? Well, again, in the Zurich paper that you have, you will see that there is a gradual return to play protocol that basically steps kids through increasing physical activity and increasing both forces to the head to make sure that they can tolerate them without either a return or a worsening of symptoms. The bottom line is that in the Zurich paper, we never return a youngster to play on the same day of a suspected injury. So if you are pulled into being a sideline doc for whether it's a youth game or whether it's a high school game, if you have any suspicion of signs or symptoms of a concussion after a blow, that youngster is done for the day. And the reason is that we know that there can be a delayed onset of symptoms. What you see on the field may look like it's disappearing, but we know in actually a very good study of college players that 30% of those players actually had delayed onset of symptoms. And this cascade of events neurometabolically oftentimes occurs right away, but sometimes can have a delayed unfolding, and it's very, very important. And so the guidance for Zurich, and you'll see the guidance from the AAP, any sign or symptom, when in doubt, you sit them out for the day and you monitor them carefully. We can then begin the gradual return to play program when the youngster no longer has symptoms. And now this is symptoms that you believe they no longer have, right? And they no longer need any medication to control those symptoms. So taking the ibuprofen with no headaches is not good enough. They have to have the headaches without the ibuprofen. Their neurocognitive functioning and their balance is back to normal. Now again, that's where you can use your resources. That's where our clinic comes in, and we can work with you on that. And obviously, they need medical clearance for that. So in Zurich, we recognized that the child and adolescent, and you saw the data as I showed you, those individual recovery curves for kids, is much longer than what we see in the typical professional athlete, where maybe it does only take them a week or so to recover. That is not the case for kids in many situations. And for some it is. For a milder injury, they may be back roughly in a week. So the whole strategy here is careful early assessment, restricting kids if there's any sign or symptom, making sure you use your tools, including neuropsychological testing, and then employing that graduated return to play program that athletic trainers can do at the schools. There also are a variety of athletic health facilities around that do it. And there's very specific guidelines here. I just sort of throw this up. You can't quite read it, but the point is there are stages and steps that we take to return to play. So in summary, we've got to do a better job, early identification and diagnosis of this injury. We've got to carefully and individually assess these kids from early on, look at full sets of symptoms, use the acute concussion evaluation to help guide your assessment. Again, getting neurocognitive testing, I think, is very important unless you have a relatively quick return for a kid. We need to actively implement treatment and management at home and particularly at school. Consider taking a day or two off from school to make sure of where those symptoms are. And again, use those home and school instructions to guide you. And also there is the care plan, which is on the website of the CDC. Remember, relying just on that motivated student-athlete's symptom report alone is a challenging process, and I do not recommend it. Use, again, neurocognitive testing to help supplement that, and that the student-athlete does not return until they are fully symptom-free, neurocognitively back to normal, after both a period of rest and after we've exerted them, and that'll safeguard our kids. And again, familiarize yourself with the Zurich guidelines and the upcoming AAP guidelines and soon the American Academy of Neurology. So again, my plea here, folks, don't dismiss the problem. Use a full assessment, use your resources, never prescribe a specific number of days alone. And the CDC really has been doing a nice job with their heads-up materials. If you go to cdc.gov/concussion, all the physician's toolkit materials are there, youth sports materials are there for parents and kids and coaches, and we just put on the website and finished a school toolkit now for guidance counselors for school nurses. So with that, we'll better take care of kids. And a final plug, some of you may have patients that participated in our emergency department study. One of the things that we are trying to do, if you have had a patient that participated, you would have received the emergency department discharge instructions. And what we're asking you to do is to help us by filling out a survey of your experience with that information regarding the tools and the communication. And we've got our two research assistants over here waving their hand in the upper left corner who can hand you one of those surveys. We really want to know what you thought and what the experience was. We're really trying to improve our care there. So thanks for your attention, folks, and we may have time for one or two questions. Yeah.
If a child is tested, has pre-participation testing, and gets a concussion, when do you want to see them back?
We like to see them as early as possible, again, because of the management issues and because, again, of the student aspect. I mean, they're out from the athlete aspect, but it's really the student management issue that we want to get on top of as soon as possible. And again, these CDC school toolkits are going to be really important to link with that school nurse, with that guidance counselor, to make sure that their academic load and their symptom monitoring is nice and systematic in school. So doing that earlier rather than later really prevents a lot of the overload on kids.
Okay, so as soon as we hear from them, we should have them call the SCORE clinic?
Yeah.
Okay.
Yeah. Yes?
You have enough staff where you send you a lot of athletes?
We see 30 to 40 patients a week in our DC and our Shady Grove sites, and then we also have a Baltimore site as well. So, I mean, we try to get kids in within that week, and so, and yeah, yeah. Yeah, baseline testing actually is the easiest thing. Yeah, yeah. Right, Mariana? It's the easiest thing. No, we actually have staff that do that regularly, daily. Daily. No, the baseline testing is not covered by insurance. If you do it for a team, we actually charge $20. If you do it individually, we charge $40 just because it's more resource. But it's...
just one question. I'm here.
Oh, okay.
I presume you're recommending doing a neuropsychological testing in an office setting for these post-concussion children.
Yes.
What tests do you recommend in the office setting for them? Because we obviously are pressed for time in the office. And what tests would you recommend for the primary care physicians?
Well, you know, the challenge is whether you feel like you're trained and prepared to do that. First of all, the neurocognitive neuropsychological testing is a brief, focused evaluation of memory and of speed of thinking, and we use a tool, it's a computerized measure called IMPACT to do that. Our CDC grant has actually allowed us to develop the pediatric version of that for kids down as young as 5. The current commercial one is available, I think, for 13 and older, and we use that, and that's a 25-minute assessment of memory and speed. And you know, the challenge I think for most of you is probably, well, it may be administering it in the office, but it's also understanding and interpreting it is going to be the challenge.
Yes. So what do we do as primary care physicians in the office when we see a child post-concussion? Because obviously if we try to refer them to psychology or neuropsychology, it'll be weeks before they can be seen.
Well, again, that's where our clinics are built to get kids in within that week, you know, within 7 days. And it's usually not our schedule, it's the family schedule that doesn't allow that.
I have a couple of questions. The first one is, I have a kid who didn't have a mild concussion, who had a major trauma, and his follow-up was not good with the specialist, as in appointments got canceled and stuff. So finally, I saw him. I said, okay, it had been a month, a little over the month. He was reporting, you know, I feel better, blah, 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 blah. And he's not an athlete, so it wasn't like I want to go back and play.
Yeah.
I sent him to school. Within 48 hours, he said, I can't handle it. So I brought him back home and put him on homeschooling until we get this. So can I send him to your SCORE clinic even though he wasn't a mild issue?
Yeah, absolutely.
Great. The next part of my question is...
And by the way, we see 2/3 of the kids we see are athletes just because that's the... 1/3 are not athletes. They're, you know, in all different types of injuries.
Okay, good enough. And then the other one is my big concern, because I know I see it, and I'm sure my colleagues in the room see, all these kids who didn't actually come to us because the coach or the trainer or the school nurse told them it was okay. Is there some kind of push to make sure that in the different jurisdictions, and all of them have different rules and different amounts of school nurses, that this information is getting out to the coaches, to the school nurses?
That's where our state law is actually pushing that. It would mandate coaching education, and also we put school personnel in there as well. You know, a lot of people don't like to be told what to do through laws, right? Well, I'm sorry, but we need a standardized universal delivery of this information, and that's where we're pushing hard. We're mandating it now in places like Howard County where this is done, but we want to mandate it throughout the state.
I want to thank Dr. Joya. The fact that there's a lot of questions, I think, points out that this is sort of an issue for us. I'm also getting the sense that as practitioners, we sort of recognize that there's a gap maybe between what the recommendations are and the way this sort of plays out in our office setting. And you know, I think that's in part why Jerry and the CDC are sort of looking at this, and I think it's something that actually, beyond referring every kid for neuropsych testing, which is the ideal vision, you know, how we can sort of manage this with our schools and our nurses and our sports teams, and so that we're just doing a better job.
Yeah, and there are some pediatricians that really have developed a specialty in this area. Mel Stern, I don't know if Mel's here today.
No, he's out of the country.
But Mel is somebody as well, and you know, this is an area that I think all primary practitioners at the very least should be actively educated on, but some of you may see this as an area of interest as well, and that's important.
And I'm sure kids have asked you, well, if I'm resting my brain, can I do video games?
I say to the point where it does not worsen your symptoms.
Okay.